The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, mania in the emergency room.
We're describing someone who's probably overactive, disorganised and chaotic.
That's Dr David Fenn, a psychiatrist who is the Deputy Chief Medical Officer at Royal Melbourne Hospital and the Director of Quality and Reform for the Royal Melbourne Hospital's Mental Health Service. And I'm presenting him with a difficult scenario.
You've got someone with what I would describe as grandiose ideas, in fact, about their own capacity and the capacity of those around them. So there's this inflated sense of self-worth.
In today's scenario, you're concerned when a young locum emergency medicine specialist submits a timesheet showing that they are working 4 to 6 hours overtime at the end of each of their rostered shifts. You make an appointment to talk to them about it. They tell you that they believe they are the only competent clinician in the department and all the staff come to them for counselling, that junior staff need constant supervision, and that they need to provide training in critical areas of emergency medicine. They say the departmental policies are outdated and often dangerous, and that management are ignoring the doctor's reports on the critical need for change. Your conversation ends in tears and the emotive claim that you are yet another manager who does not take their concerns seriously. Other staff and management in the department express concern that the doctor may be out of control, although their clinical decision-making seems fine. Staff find the doctor very hard to work with. The department director urges you not to employ them again. Although there may be an element of truth in some of the doctor's allegations, the department is well run and safe. You are concerned that this locum doctor appears manic and may have a significant mental health condition. I started by asking David Fenn what issues this scenario raises.
Well, there are a number of concerns. The obvious and foremost one is that of safety for the public, given that this is an emergency specialist operating in an ED, a senior doctor is responsible for the care of the public as they come to the emergency department. Secondly, I'm concerned for the welfare of the doctor, of course. It appears that this is an impaired doctor, in fact, who needs diagnosis and probable treatment. So we have considerations for the welfare of the doctor. But of course there's also the issue of the staff of the hospital, staff of the emergency department, their confidence, their capacity to work and the impact that this situation is having on them. So they're the first three things I'd be thinking in the short term.
Most medical directors or medical leaders are not psychiatrists, and we're not trained to make a mental health diagnosis. How do you go about validating your hunch concerns?
Yeah, well, obviously as a psychiatrist, I think in terms of history and mental state examination, and as you've described the scenario, David, we're describing someone who's probably overactive, disorganised and chaotic. You've talked about staying over the shift beyond 4 to 6 hours on a regular basis, which suggests poor organisational capacity. You've got someone with what I would describe as grandiose ideas, in fact, about their own capacity and the capacity of those around them. So there's this inflated sense of self-worth. So these are typical symptoms of a manic presentation. So strongly suggestive of mania. The other features of, you've described it as the affective lability. She's tearful, or she is tearful at the end of the conversation. There's this sense of irritability in relationships with the other staff members. And maybe I'm reading more into it, but this sense of an expansive mood, all of which are suggestive of a manic presentation.
Unfortunately, mental illness has stigma attached to it. How do you go about getting a person like this with very little insight to get to see a psychiatrist so you can get the diagnosis?
Yes, well, that's always the challenge, David. How do we go about convincing someone that they have to see someone? And of course, you start off with gentle persuasion and recognising that we're actually on the side of the doctor in this situation. We're wanting to get help for them. And if we can convince them that that really is the way forward, well and good. But unfortunately, sometimes that doesn't work, and we have to enlist the support of others or require them to seek treatment. As in this situation where you've got someone who may be actually endangering the public, we've got a few choices here. They have to see someone if there's any opportunity or hope that they can continue working.
As you said, one of your major concerns is for the safety of patients that they're caring for. How do you go about making sure that they are actually delivering safe care to the patients they see in the emergency department?
Yes, well, obviously you're looking for evidence that no harm has been done to date, and you've consulted the staff in the department who've indicated that as far as they can see there have been good clinical decisions made. I don't think as an administrator in the hospital you're going to be satisfied with that, though. You're going to want to look back and review the cases that this doctor has been looking after and making sure that there's no evidence of harm. And if so, that's going to have to be managed in a very formal way going forward. So you need objective evidence that no harm has been done in fact and that practice is safe.
That can be quite tricky because the head of department's likely to be their friend. These people tend to be gregarious, social, and the head of department may be reticent to review files for you. So what are your options?
Yes, well, I think that there are other options apart from reviewing the files, of course. You'd be looking for complaints,
right.
Evidence of any incidents, those kinds of issues. But realistically, in these sorts of situations, in my experience, a number of staff will be concerned and have likely raised concerns apart from one or two or three that they may be good mates with.
So what are you going to do? What are your immediate actions?
Yeah, well, at this point, I'm not confident that this doctor can continue in the role, and I'll be more than persuasive in asking them to stand down for the time being until the situation is resolved and working out a plan with them, hopefully, that they'll accept. Consultation with a psychiatrist in this case and instituting treatment. And realistically, I wouldn't be wanting this doctor back in the department until it was clear that they were engaged in treatment and treatment was effective and that, the treating practitioner had actually signed off that this doctor was fit to practice. Yeah.
These doctors don't work in isolation. Everybody in the department's got their opinions about who they are and what their issues might be. And it may be much wider than the department, the emergency department, sort of the hub of the hospital. And so others who visit the emergency department may have had concerns. How much can you disclose to them about the actions that you're taking or the concerns you might have?
I think you have to be very careful, really, David. I mean, this is a doctor's reputation. That's at risk. The doctor is entitled to confidentiality as to their own health concerns, and we have to be respectful of that. I'd certainly be wanting to talk to the immediate supervisor, immediate head of the department, whoever that might be, and there'd be one or two people like that have to be involved and informed. But as a rule, there's a cloak of secrecy, a cloak of confidentiality which surrounds what we do here.
We're short of doctors in Australia. It's all very well standing them down, but how do you support them so that they can safely return to work?
So, I mean, that's the ideal outcome. Hopefully that this doctor accepts the need for treatment and supervision. And I'd be looking at, once I've got some sign-off from the treating practitioner that they're fit to practice again, I'd be wanting to bring them back into the department in a graduated fashion, gradually building up shifts again and having arrangements in place that there's appropriate supervision in place, support for the doctor as they come back to work gradually, and a gradual reporting process over time, so monitoring very carefully progress over a period of time. And in my experience, that's quite achievable in many cases, but it really is contingent upon the doctor cooperating with that process.
There can be quite significant legal risks in a case like this. The doctor without insight may well sue you as being an inappropriate clinical leader, but the patients can also raise issues about the standard of care they've received. So at what point do you bring legal into conversations like this?
Yeah, so as we indicated earlier on, we're going to be conducting a look back at the cases that this doctor's been involved with. And hopefully there's nothing to find, but unfortunately there may well be things to find. And in that case, of course, you're embarking upon a whole process of review of open disclosure with the patients and their families and any other staff that may well be involved. So it becomes a matter of managing that risk. At that point, the legal department of the hospital will be involved, potentially notification of insurers and so forth, that if negative consequences have ensued. And all of that, of course, has reputational issues for the hospital and for the doctor, of course, concerned. Yeah.
It's very likely at the second conversation they'll have an advocate. Either the AMA will come to support them, or how do you deal with the advocate when you've got a doctor who lacks insight?
Well, I just think we have to put the facts on the table, David. You identify what the hard evidence is and you present it. And, of course, the legal advocates will create a narrative which is in the best interest of the doctor involved, and that's fine and appropriate, of course. But at the end of the day, we have to deal with the hard facts that are before us and respond appropriately. And, of course, we'll have our own legal advice as you walk through this process.
And as you said earlier, your priority is always patient safety. That's your prime responsibility.
Indeed.
Yeah.
Indeed.
Yeah. So the doctor's a locum. Locums are usually brought to your attention by a locum agency, and there may well be other organisations that they get nominated for. First of all, how much do you tell the locum agency about your concerns?
Look, if this doctor is not safe to practice, there is the question of notification of the authorities. And if the doctor is not willing to notify the regulatory authorities themselves, and of course they have responsibility to their own employer, to the locum agency, to be open and transparent about their own health. If they're not open and transparent, well, that introduces a whole new scenario, really. And of course, we are mandated, where we've got concerns for substantial risk to the public, to notify the regulatory authorities. And we'd have to consider very carefully what was said to the locum agency. Yeah.
The other scenario is that another hospital who's considering engaging this locum is looking at referees and call you and say, I've got this doctor's CV in front of me. How did they go?
I would be getting some legal advice is the first thing I would say. I'd be getting some legal advice. But again, we have to be open and honest about what we provide. I mean, at the end of the day, the primary concern here is safety for the public. And we have to be confident that if the doctor is going to be employed elsewhere, that they're in good shape. And that has to be the foremost consideration in my view.
So talking about the regulator, at what point do you notify AHPRA?
So my experience in the past has been that so long as the patient has been withdrawn from service and is engaging in treatment, well, there is no risk to the public at that point, on the proviso, of course, that they're not moonlighting somewhere else. But there is always the risk, particularly with locum doctors, that they may well be working somewhere else. So I think there's a priority, in fact, of notification to AHPRA. Ideally, we encourage doctors like this in this situation to self-notify. It works much better for them and for everyone else. But at the end of the day, if that doesn't occur, it becomes an urgent priority because we can't have the public put at risk.
In your look back, issues of concern are raised with the treatment provided to a few of the patients that this doctor's seen. What do you tell the patients as far as open disclosure, in an open disclosure context, about the treatment that they received at your hospital?
Yeah, look, I think it's going to depend on exactly what the circumstances of each case are, David. There's a dual consideration here. There's the reputation of the hospital. There's also the reputation of the doctor. And you've got to balance that with the needs of the patient and the priority of looking after the patients. And I think it's very hard to predict how that will play out. But you have to be as open and transparent as is reasonable and make sure that the patients actually get good care, that there's an ongoing plan and management for their ongoing care, and that they can understand something of the situation and be aware that the hospital is concerned to put anything right that hasn't been done well in the past.
I think if you're able, it always helps to be open with the doctor and tell the doctor what you're going to communicate to the patients that may not have received the treatment. So there's no surprises if anything comes back to them.
Absolutely.
Yeah. So they come back in 6 months' time and say, I'm all fine, all cleared, here's a certificate, I want to work in your hospital again. What assurances or process do you go through to consider re-engaging them?
Well, there's a number of considerations. I mean, obviously the formal certification is important. I think any hospital will be concerned for the well-being of their own staff that are currently employed who may well have been working with this doctor. And there's got to be confidence in the department that this can work. So I'd be consulting with my staff in the hospital and the department they were working to see if that was actually feasible or not. I think that's one of the first things. Hopefully you're not in such a desperate situation that you really do feel compelled to go down that track. Obviously, we're concerned to look after our medical staff and provide opportunities when and where we can. But equally, the hospital has to function, and sometimes these situations are best left alone.
Thank you, but no thank you.
Something of that nature, yes.
Yeah. Any final comments or observations on what can be a really sleepless night for a medical administrator?
I think these are really tough decisions because obviously we have to look after our patients and that's our first priority, but these are our colleagues that we're talking about, and we have respect for one another, and of course any one of us could be in a situation like this at any point in the future. And it's important we do what we can to look after one another.
That was Dr David Fenn, a psychiatrist and Deputy Chief Medical Officer at Royal Melbourne Hospital.
And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.